The People's Pharmacy podcast is supported in part by CocoVia. CocoVia cocoflavanols support both cardiovascular health and cognitive function by promoting healthy blood flow, transporting oxygen and nutrients to vital organs and muscles, including your heart and brain.
CocoVia now comes in an even more concentrated formula with 450 milligrams of cocoflavanols, 5 times more than the leading dark chocolate bar and 15 times more than the leading cocoa powder.
CocoVia has a proprietary process that preserves cocoflavanols at the highest levels, and the product undergoes rigorous testing at every stage, which allows them to guarantee the highest level of cocoflavanols per serving and to provide the purest, highest quality product possible.
People's Pharmacy listeners can now try CocoVia for 25% off by using the code Peoples25 at cocavia.com. That's COCOAVIA.com. Billions of dollars are spent advertising prescription drugs on TV. Has that led to Americans taking too many meds? This is the People's Pharmacy with Terry and Joe Graydon.
Every day, about 750 older people land in the hospital as a result of prescription drug side effects or interactions. Polypharmacy is the other drug problem in America. When one medicine causes a side effect, it's not unusual for the healthcare provider to prescribe another drug to treat that symptom.
Is there any way to reverse the trend towards increasing prescription drug use in America? Can doctors adopt a culture of deprescribing in the face of so much advertising?
Coming up on the People's Pharmacy, what we can do about the other drug problem.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Americans take an awful lot of prescription drugs. In 2018, we filled 5.8 billion monthly prescriptions. That works out to more than 17 prescriptions per person each year. About 2/3 of these are for chronic conditions, so people take them day in and day out. Aside from the cost, which is considerable, so many people taking so many meds can have health consequences like side effects and interactions. Are you taking too many meds? What about your parents or grandparents?
To learn more about this important topic, we turn to Shannon Brownlee. She is Senior Vice President of the Lown Institute, a nonpartisan public policy think tank based in Boston. She's also co-founder of the Right Care Alliance, a grassroots organizing network of patients, clinicians, and community leaders advocating for a radically better healthcare system. Her groundbreaking book is Overtreated: Why Too Much Medicine is Making Us Sicker and Poorer.
Shannon Brownlee, welcome back to the People's Pharmacy.
It's great to be with you again.
Shannon, the study that you all have done at the Lown Institute on medication overload, how the drive to prescribe is harming older Americans, is nothing short of, well, shocking doesn't cover it. I mean, it's unbelievable. The idea that 750 older people are hospitalized due to serious side effects from one or more medications is, I mean, that's
every
just
day.
Bizarre. That's every day. Tell us about your study. What prompted it? And are you as shocked as we are?
You know, I am shocked. And it's sort of surprising that all of us are shocked, since the three of us certainly are aware of how prevalent medication problems, how prevalent they are, especially in older people, because they have multiple illnesses. But the study came about because we were speaking with a program officer at a funder, the Gordon and Betty Moore Foundation, which has long had an interest in medication for older Americans. And they said, "What do you know about polypharmacy?" And polypharmacy is defined as when a person is taking 5 or more medications. And I said, "Well, I don't know very much about it. but let me go away and find out. And I did a little bit of preliminary research and realized that this was a field of study that was opening up and revealing that this was an enormous problem among older people. 40% of older people are on 5 or more medications every single day.
And let me ask you to pause right there, because what we're talking about, if I'm not mistaken, is prescription medications. That doesn't necessarily include over-the-counter drugs, dietary supplements, herbs, who knows what. So it could be a lot more than that.
Yes, it is a lot more than that when you include all of those drugs. And the really scary part about this is that the number of people who are on multiple medications is increasing. Over the last decade, it's gone up more than 300%. 20% of people over age 65 are on 10 or more drugs, and it's not unusual for people to be on 20 or more.
Do we have any idea why the number of people on so many drugs has risen so rapidly?
Well, it's a very sort of multifactorial problem. Part of it is that people are living longer and they have more chronic illnesses. The longer you live, the more likely you are to have a chronic illness like heart disease, like diabetes, like arthritis. It's also that the drug industry has been churning out new products for this time. And it's that nobody has really stopped to say, now, wait a minute, is this really what's the right thing to keep people not only healthy, but also to make sure that the quality of their lives is as good as possible as they age?
How has this changed? I mean, I think back to my mother, my dad, grandparents. I mean, 50, 60, 80 years ago, people might take 1 or 2 medications, if that. If they had something wrong with them, obviously, an infection, they would take an antibiotic. If they had high blood pressure, they would take a medication to lower their blood pressure. But we now take a lot of quote-unquote preventive medicines, which brings us to the statins. It brings us to a number of other drugs that you're supposed to take to stay healthier. But when we add those up, as you say, it adds up to 5 or 10 or in some cases 20 different medications, even if we don't have 20 different ailments.
So that's exactly correct. And a lot of this has to do with the drug industry's marketing. So the drug industry has ramped up marketing tremendously since the late 1990s. You guys know that that's when direct-to-consumer marketing kind of exploded. And that's when the marketing to physicians and other people who prescribe also ramped up at the same time, mostly for these kinds of, quote, lifestyle drugs or preventive drugs. These are drugs that you have to take, you supposedly have to take for the rest of your life to prevent some event happening down the road, like stroke, like heart attack, like
osteoporosis.
Osteoporosis, exactly. And so it's been that, which is this very, very intensive marketing to clinicians and other prescribers, coupled with the fact that physician groups have started to put out, over the last 25 years, they put out something called clinical practice guidelines. And these guidelines are supposed to be based on the best research available, and they're supposed to help doctors and other prescribers know how to treat specific diseases. And many, many, many of these guidelines include instructions about hitting targets, clinical targets, like your blood pressure is supposed to be 120 over 70 is supposedly healthy blood pressure. Well, people who are older are supposed to not get above, say, 130. And if they're not there, you're supposed to ramp up giving them blood pressure medication so that they can hit that clinical target. So these guidelines have had a very powerful effect on the way doctors and other prescribers treat different diseases. And often they will ramp up the medications in an effort to hit those clinical guidelines.
Sometimes those guidelines are used as a way of evaluating whether the doctor is actually doing his or her job.
Yes, and in many cases, it's not really the right thing for the patient. This is the kind of tragedy of this effort to improve quality by giving these doctors these targets, is for some patients, if you're 50 years old and you've got high blood pressure, probably aiming at that perfect blood pressure is a good idea because you have conceivably a long life ahead of you. If you're 85 years old, trying to hit that narrow little target blood pressure can actually be detrimental because when you take multiple blood pressure medications, you are often at greater risk of being dizzy, being lightheaded, and falling.
And that, of course, is devastating for an 85-year-old person or anyone in their 80s.
It can be devastating, exactly. So this is the sort of multifactorial nature of this problem, is that the marketing has been very heavy. The clinical guidelines, which might or might not be the right thing to do for that individual patient, are at work. And plus that, when you have multiple medications, you're often seeing multiple different doctors. And one doctor has no idea that the other doctor has already prescribed, say, a high blood pressure medication to you.
This is how our healthcare system is not a system.
No, it's not a system. It's a fragmented, marketplace, crazy marketplace.
But wait a minute, Shannon. We now have electronic medical records.
Oh, yeah.
It's supposed to have solved this problem. So if you go to the dermatologist, it's in your medical record. If you go to the gastroenterologist and the cardiologist and your intern, everybody has access to your electronic health record, and they're supposed to review everything, and everything is supposed to be hunky-dory. What happened?
Right. Well, there's a couple of things. The person who's supposed to be able to really serve as your guide in all of this and to keep track of all of this is your primary care physician. But here's the problem. Your medical record at your dermatologist is in your dermatologist's medical record, and your record at your cardiologist is in your cardiologist's medical record, but those two records don't talk to each other. When the federal government set up the plan to make sure that all physician offices, that all hospitals had electronic medical records, they failed to say, and oh, by the way, here is the standard for interoperability so that they can all talk to each other. They sort of said, oh, the market will sort this out. Well, the market has not sorted it out. So the medical records cannot talk to each other. And so your physician often only knows what you're taking when you bring it in a little brown paper bag. Bring in all your pill bottles in a brown paper bag. And that's a crazy way to try to ensure that people are on the right drugs.
Nonetheless, we often recommend that people do that, especially older people who may be taking a lot of drugs.
You bet. As long as electronic records don't talk to each other, and as long as physicians are not talking to each other, which they're often not, especially when your primary care doctor is so rushed, the best thing you can do is go in with your pill bottles in a bag, every pill bottle, including the non-prescription things you're taking, and say, let's have a chat about what drugs I'm on.
You're listening to Shannon Brownlee, Senior Vice President of the Lown Institute and co-founder of the Right Care Alliance. She's author of Overtreated: Why Too Much Medicine is Making Us Sicker and Poorer.
After the break, find out about the prescribing cascade.
How does one drug lead to another and then a third?
This results in dangerous drug interactions that may put people in the hospital.
How can we solve this problem? Should doctors be de-prescribing?
Find out when you should get a brown bag pharmacy review and how Ms. Brownlee's 6-point plan would work.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored by Mighty Muscadine Grapeberry, king of the superfruits, 100% natural plant-based supplements, juice, snacks, and more.
The muscadine grape is a berry, providing greater health benefits than blueberries, cranberries, and the whole berry family with oxidative damage-fighting antioxidants to support cardiovascular, immune system, and joint health.
At Mighty Muscadine, full-time chemists and food scientists check all their products for quality and purity. Find out more online at mightymuscadine.com. The People's Pharmacy podcast is sponsored in part by Kaya Biotics. KAYA Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's KAYA Biotics.com. Use the discount code PEOPLE for $10 off your first purchase.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon.
The People's Pharmacy is brought to you in part by Mighty Muscadine Grapeseed and Skin Products. Natural supplements, juice, and snacks containing antioxidants that research indicates may support cardiovascular, immune system, and joint health. Information online at mightymuscadine.com.
And by CocoVia, the maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocovia.com.
And by Verisana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
Today we're discussing the problems of overmedication. Older adults seem to be especially vulnerable to side effects and interactions from prescription medicines. Is there any way to protect them, and all of us, from accumulating unnecessary prescriptions?
Our guest is Shannon Brownlee. She's Senior Vice President of the Lown Institute, a nonpartisan public policy think tank based in Boston. She's also co-founder of the Right Care Alliance, a grassroots organizing network of patients, clinicians, and community leaders advocating for a radically better healthcare system. Her groundbreaking book is Overtreated: Why Too Much Medicine is Making Us Sicker and Poorer.
Shannon, there's another factor at work here as well. It's something we call the prescribing cascade. So you get prescribed a medication, maybe a medication to help you sleep at night. Okay, so you're taking Zolpidem. The brand name was Ambien, but now everybody takes Zolpidem. And hey, great, you can go to sleep. But you have the most horrible heartburn. So your doctor says, no problem, we'll just prescribe you omeprazole. Brand name was Prilosec, but now everybody takes omeprazole. So now you've got 2 drugs on board instead of just one, and twice the opportunity for side effects because you're taking that second drug in order to treat the side effect from the first.
And maybe the second drug has a side effect, and that leads to a third and a fourth and a fifth.
You're absolutely right. The prescribing cascade is really quite common because physicians don't necessarily know all the time whether or not what you're suffering is a new condition or a side effect from a drug you're already taking. And if the physician doesn't actually know you're on a drug that can be causing that symptom and that side effect, they really are trying to operate in the dark and end up prescribing new drugs. The other piece of the problem here, though, again, kind of relates back to the pharmaceutical industry, which is that people now think there's a pill for every ill. We have direct-to-consumer advertisement on television, and it's very targeted at an older audience. So, older people watch the news. That's where a lot of the drug ads come on. And these drug ads convince people that everything is treatable with a pill. So the patient comes in saying, oh, well, I'm having a little bit of heartburn. Can you give me something for it? Instead of trying to get to the bottom of the problem. And so the prescribing cascade is very real, but it is exacerbated by this belief that medications are the solution to all ailments and all problems.
There's another issue here, and it has to do, again, with that electronic health record. We thought the problem of drug interactions, incompatibilities, would be solved once computers took over the world. That, the doctor would get ready to write a prescription, and there'd be this whole long list in the computer that would tell him or her, oh, that's not a good idea. There's an incompatibility. Don't do that. Well, there are two issues here. Number one, I'm not sure that doctors look at all of the drugs in the electronic health record because, a technician, maybe a nurse, has done all of the data entry before the doctor walks in the door to save time and make it more efficient. But number two, there's something called alert fatigue. Can you tell us a little bit about what that means?
Oh, yeah. So we human beings get really good at ignoring annoying things. And when the doctor is looking at your medical record and there's a alert, it's so annoying that they either find a way to turn it off or they simply ignore it. And so many things so many decisions that the doctor is trying to make in the course of treating a patient, those decisions show up on the screen and start alerting that they start to ignore them. And then they can miss really, really important drug interactions.
So, Shannon, we have looked at the problem. And once again, I want to remind our listeners, 750 older people in the United States, that's 65 and older, are hospitalized due to serious side effects from one or more medications every day. So this is a major issue, and I suspect there are some deaths associated with this complication. Yes. What do we do next? How do we solve this problem?
So I think patients can have a really important role in solving this problem. There are systemic things in the healthcare system that have to change at the same time, but patients can help themselves. The first thing to do is ask yourself, how many medications am I on? And if you're on 5 or more, that doesn't necessarily mean there's a problem, but what it means is that's a risk factor for a problem, for having a really serious adverse drug event that might land you in the hospital. So what you want to do is you want to gather up all the medications you're taking over the counter as well as prescription, and you want to make an appointment with your doctor, and you want to say that this is an appointment. This is not just a quick checkup appointment. This is a longer consultation, and you want to ask for a prescription checkup. You want your doctor, your primary care doctor is probably the right one, to really go over your medications with you and talk about what each medication does, what its chances of benefiting you are, and what its chances of harming you are, and whether or not you really have to be taking every single one of those drugs. I think people assume that because the cardiologist prescribed it, or because the primary care doctor prescribed it, or because the rheumatologist prescribed it, then you must need it to be able to live a good life and a long life. And that's not necessarily so. So it's worth talking to your primary care doctor about all of these drugs. And your doctor may not be able to do it in one sitting if you're on a lot of drugs. So you're going to have to be ready to do it more than once. And basically do part of the job in one visit and then maybe come back and finish.
So the primary care doctor may actually be a little bit reluctant to mess with a medication that a specialist has prescribed. A cardiologist, yes, for example, or a neurologist may have prescribed something, and the primary care doctor may not feel confident about de-prescribing that particular medication.
That is exactly the case. Primary care physicians, in fact, are often a little bit hesitant to de-prescribe a drug that your specialist prescribed. And there are ways around that. If you feel like a drug is causing some side effects, you really need to kind of get to the bottom of it and really get your primary care doctor to take it seriously and say, well, maybe you could talk to my cardiologist, or I need to go visit the cardiologist and I will bring it up. And, I know what I'm saying can be a little bit daunting for patients and even for families of older patients. We tend to think of the doctor as the all-knowing doctor, and we tend to think of drugs, if they got through the FDA, they must be approved, they must be safe. But in fact, as anybody who listens to your show knows, not all drugs are as safe as they might seem, and they're certainly not as effective as they've often been marketed as being.
And they're certainly not safe for everyone under every circumstance.
Yes.
One of the problems I'm imagining, thinking about people I know in their 90s, they're really not necessarily going to be capable of asking the doctor about this. So they may need an advocate to go with them when
Yes.
they're doing this check. Let me ask you, Shannon, also, can you take your brown paper bag full of all of your bottles to the pharmacy?
You can. Your pharmacist may be a very good person to talk to. And in fact, some of the sort of leaders in the movement within healthcare to really improve medication overload and reduce it are pharmacists. The issue you have to address is whether or not your pharmacist is going to know all of the conditions that you have and be able to really talk to you clearly and in a way that you can understand or your family member can understand. And this goes for your doctor as well, about what the possible benefits and risks are of the different medications. So that's one of the things you have to kind of try to take into your own hands, is say, I don't understand. You need to explain this to me really, really clearly. And I hate to say it, and this complicates the situation a little bit, but while pharmacists are incredibly well trained to recognize side effects, to know the side effects, to know the possible benefits of drugs, so far, when pharmacists have been in charge of trying to reduce medication overload or to ensure that patients are really on the right drugs, they end up taking more drugs, not fewer.
Wow. There's also another problem, and that is what I would call the power imbalance. So if a pharmacist discovers, let's say, an incompatibility, and we've talked to pharmacists who have described this to us, here's an interaction and I'm a little worried about it. First of all, if they try to reach the prescriber, that can be a challenge because doctors are always seeing patients and they're always busy and you always have to wait for a callback and it can take days.
Yes.
But then it's like, wait a minute. A pharmacist is challenging a cardiologist? I mean, who the heck do you think you are? And now, there's a certain amount of defensiveness on the part of the pharmacist or the part of the nurse who might also be involved in this process. And so, and quite candidly, if a patient says, I've got all these aches and pains, I can barely get up out of the chair, I'm taking this statin, it's causing me all kinds of mischief.
But you're over 65, you're getting older. What do you expect?
It's just aging. And so if the person says, gee, doctor, I'd really like to, stop the atorvastatin or the simvastatin, the doctor may also get defensive and say, well, you want a heart attack? I mean, who's the doctor here? And
which one of us went to medical school?
Yeah, exactly. And so when there's this power imbalance between the physician and the pharmacist, the physician and the nurse, the physician and the patient, it doesn't always end well.
No, and you're absolutely right. And so I recognize that what I'm recommending, that you go in for a prescription checkup, is not always going to go smoothly. But every patient should be looking for a doctor who really talks to them and who listens. And I know patients really dislike switching doctors, and so I'm not going to recommend that. But you can find ways to talk to your doctor. Sort of like you had to find ways to talk to your teenager, that didn't make them defensive. There are ways to talk to physicians to get them to really start to listen and to pay attention and to say, I know you're the expert. I realize that I have far less training than you do, but I feel really strongly about this. I really, really would like to find a different, I really don't want to take this statin, or I really do think this statin is causing this side effect, or I really do think that I'm on too many blood pressure medications. And I think most good primary care doctors will ultimately start to really try to listen to their patients. They went into primary care. They're really a kind of a different breed of doctor. And so there may be a way to really get a real conversation going with your doctor.
And
I'll tell you a very quick story about
do,
that.
Please.
Yeah. So I, when I was in my 40s, my primary care doctor kept telling me it was time to get a mammogram. Every year that I would go in, she would say, time for a mammogram. And I'd say, and I'd take the mammogram prescription and I'd throw it in the garbage. So I thought, this is really silly, because I knew that the evidence was very poor for mammograms, really for the average risk woman in your 40s and even frankly in your 50s and 60s is not what I wanted to do. So, and I knew the evidence. So one day, finally I went in and I said, doctor, you and I are on different sides of a debate. And that doesn't mean I think you're a bad doctor. And you can't think I'm a stupid patient or an uncompliant patient. I'm really well informed. So I don't want to have mammograms. And she said, well, gosh, you're right. What do we do about this? And we had a real conversation about it. So doctors often are willing to have real conversations, but you can't back down the minute the doctor says, well, what do you want, a heart attack? No, I don't want a heart attack, but I do want to get off this drug.
Shannon, what is the message of this report? I mean, what would you like to accomplish, and what would you like to see as the outcome, say, in the next decade?
I want two things. In the short term, I want patients to start asking for prescription checkups. It's going to take a lot of doctors by surprise. But in doing so, patients will be alerting their doctors to the fact that they don't necessarily want to be on lots and lots of drugs for the rest of their lives. And families can do the same thing. We don't think that grandma at 90 necessarily needs to be taking a drug that's supposed to prevent an event in the future. She's had a great life and this drug is bothering her now. So that's one thing I want, is for patients to start asking for this and start the ball rolling. And then what I want is for the organizations within healthcare to start taking this as a serious problem and starting to do the things that are necessary to address it. And what are those things? Well, we are in the process of working with an expert panel of about 25 wonderful, dedicated clinicians, patients, pharmacists on an action plan. And our action plan will come out in January. And it's a national plan that looks at the 6 major areas that need to change within healthcare in order to address this big problem. And some of them will be easier to address than others, but all of them need to be looked at and addressed by both the forces within healthcare, like the specialty societies, like the AMA, like the American medical colleges, but it also needs to be looked at by regulators on the outside, by the FDA, by Congress.
Shannon, can you give us a quick executive summary of a couple of the top items on your 6-point plan?
You bet. Well, implementing, getting prescription checkups to be a normal part of primary care is one of the key ones. Another one is increasing awareness of the problem. We think that direct-to-patient efforts can really help a lot. Little brochures, for example, saying you're on a benzodiazepine, things like Valium or benzos. Maybe you want to think about that and talk to your doctor about it. Those kinds of direct-to-patient efforts to increase awareness of the problem is going to be, I think, a really big part of it, and also increasing awareness among prescribers who may not know just how much harm is being done.
Shannon Brownlee, thank you so much for talking with us on the People's Pharmacy.
Thanks, guys. It's always a pleasure.
You've been listening to Shannon Brownlee, Senior Vice President of the Loan Institute. She's also author of Overtreated, Why Too Much Medicine is Making Us Sicker and Poorer.
After the break, we'll turn to Dr. Cynthia Boyd and learn how our pill for every ill culture affects the practice of medicine.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This People's Pharmacy podcast is brought to you in part by Verisana.com.
Verisana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's uppercase PEOPLE. To learn more, go to Verisana.com. That's VERISANA.com.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Coca-Via, offering plant-based nutrients in the form of cocoflavanols for brain and heart health. Online at Coca-Via, that's COCOA via VIA.com.
And by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
Also by Mighty Muscadine grape seed and skin products, natural supplements, juice, and snacks containing antioxidants that research indicates may support cardiovascular, immune system, and joint health. Information online at mightymuscadine.com.
If you watch television news, you might be struck by how many of the ads are for prescription drugs. It might seem like there's a pill for every ill. We've just been discussing the problems this attitude can create if you end up taking too many meds. What can we do about it?
Our guest, Dr. Cynthia Boyd, is professor of medicine at the Johns Hopkins University School of Medicine. She holds a joint appointment in health policy and management and epidemiology at the Johns Hopkins Bloomberg School of Public Health. Dr. Boyd is a core faculty member at the Johns Hopkins Center on Aging and Health, the Center for Transformative Geriatric Research, and the Roger C. Lippitt Center for Integrated Healthcare.
Welcome to the People's Pharmacy, Dr. Cynthia Boyd.
Thank you very much. I'm really looking forward to our conversation.
Dr. Boyd, anyone who watches television these days will see an absolutely unbelievable number of prescription drug commercials. I mean, there's a pill for every ill, or at least it seems that way. There's Humira and Xeljanz for psoriasis and rheumatoid arthritis. There's Lyrica for fibromyalgia. There's Jardiance for type 2 diabetes, just to name a few. And I think all of those commercials make it seem like prescription drugs are the only solution for what ails us. And even though they have a long list of side effects, they're usually accompanied by visual images of people just having the best time, even though the drug in question might cause liver failure and heart attacks and even death. I wonder what's wrong with this picture. I mean, it just seems like our culture has embraced prescription drugs, especially for chronic conditions and for older people, in huge quantities. Any thoughts about that?
Yeah, I think you raise a number of good points. So I would definitely say that we should always be thinking about strategies without the use of medications or over-the-counter medications can help us address chronic conditions and symptoms that people of all ages have. Certainly, older adults are a group that are often prescribed a very large number of medicines. But I think that the idea that is communicated with the advertising you described, that medications are this wonderful solution. And I do think people are really swayed by those images that accompany the descriptions of the drugs, really present this idea that contributes to our culture of prescribing. I certainly would say that medications are often very effective, and we have really good evidence for some medications for some conditions. But I think what happens sometimes is in the advertising you describe is we're not really seeing the full picture. And my hope would be that patients and their families and their clinicians, doctors, pharmacists, nurse practitioners, et cetera, that people are really having real conversations about the potential benefits and the potential harms and how we really should be making decisions about medicines. My hope is that we are not overly swayed by that advertising.
Dr. Boyd, older people do take multiple medications. Do we have any idea why?
So I think one of the reasons many older people take multiple medications is because they often have multiple coexisting conditions, and that the way they arrive at taking multiple medications may be a result of trying to help those multiple conditions. Certainly, there are many conditions which we often end up prescribing multiple drugs just for one condition. And so the cumulative impact is that many older adults end up on many medications. We need to figure out when the use of multiple medications means that people are going to get more harm than benefit. And we need to think about when people are at an increasing likelihood of having something bad happen to them as a result of being on multiple medications, like an adverse drug event.
Well, let me ask you this, Dr. Boyd, because there was an interesting study not too long ago in the JAMA Internal Medicine Journal, in which they were looking at intensifying antihypertensive medications as patients were discharged from the hospital. And what they found was, sort of following the guidelines, and we'll come back to the issue of guidelines in a moment, whether it's for diabetes or whether it's for heart disease and statin prescribing. But in this particular case, these were non-cardiac patients who were discharged from the hospital, and some of them got very intense antihypertensive medications, presumably to get people down to 120 over 80, which is sort of what the guidelines are recommending. And I'll just quote from the conclusions. Among older adults hospitalized for non-cardiac conditions, prescription of intensified antihypertensives at discharge was not associated with reduced cardiac events or improved blood pressure control within 1 year, but was associated with an increased risk of readmission and serious adverse events within 30 days. Any thoughts?
That's a great study, and I think it is fascinating for a couple of reasons. One is thinking about the fact that the moment when someone's been in the hospital and they're transitioning home, I think is a particularly tricky one for thinking about intensifying medications that are trying to treat a chronic condition, high blood pressure in this example, that it actually takes a significant period of time to accrue any benefits of lowered blood pressure. And so I would say that one thing we might want to think about based on that study as well as other literature is whether we really want to be thinking about intensification when people are in sort of a stable state. So not just in the hospital, working with their outpatient provider that knows them sort of in the context of their usual life as opposed to just being in the hospital. But I think it's actually a perfect example of that we may have reasons to think doing something is beneficial, but we really need to be thinking about unintended consequences and that more is not always better. One of the things I love about JAMA Internal Medicine actually is that they've had this section, which is called, if I'm getting it right, like less is more, which is that the idea that more intense treatment, more medications, just more healthcare is not always actually better for people. And it's certainly tricky because there's no question that treating high blood pressure is also beneficial and has reduced cardiovascular events in many cases and in many patient populations.
Well, we too love that feature of JAMA Internal Medicine, Less is More. Tell us, Dr. Boyd, how do guidelines contribute to the possibility of overtreatment?
So, guidelines are really meant to be guidance for clinicians, for physicians, and other healthcare professionals. That's sort of implicit in the word, that they are not necessarily meant to be mandates of you must do something. They certainly are useful in that they are really meant to be bringing together the best available evidence synthesized in a trustworthy way by groups of clinicians to try to give guidance to healthcare professionals, across the country, across the world, about what the best available evidence says is recommended for a particular situation. I certainly believe that guidelines should be created in a trustworthy way. And the Institute of Medicine, now the National Academies of Medicine, put out guidance a few years ago about how you actually arrive at trustworthy guidelines. And so a lot of things which I think are important to mention here is you want these groups of experts to be as conflict of interest free as possible, but also because it's impossible to get rid of all potential conflicts of interest sometimes, but that those really be managed in a trustworthy way so that people are not, for example, taking funding from pharmaceutical companies that make a drug that is applicable in that clinical situation. But the way guidelines end up being used, often created and used, is that they tend to focus on a specific condition, like high blood pressure, like diabetes, like chronic kidney disease. And they, to varying degrees, address the fact that most people with all of those conditions actually have a lot of other conditions. And I think this sort of perpetuates this sort of single disease approach to care. The other issue with the way that I think guidelines can end up contributing to polypharmacy and medication overload are that they often are used as the basis for quality standards, which are then used to judge clinicians about how well they're practicing according to the best available evidence. And so they can end up having a lot of weight. So I think it's really important that guidelines recognize that many people with whatever condition they're focusing on actually have multiple conditions, and make sure that they are actually able to be used to inform really good conversations and decision making between clinicians and their patients and family members. So I also think that they would do a better job for people if they were really focused on providing the information needed for clinicians and their patients and loved ones to really be considering those balances of benefits and harms in a thoughtful way so that people can make the decisions that are right for them.
Dr. Boyd, do you have any recommendations for patients or patients' families when it comes to multiple medicines? Sometimes clinicians like to get very aggressive, whether it's blood pressure treatment or you must take a statin, and patients go, but yeah, my muscles hurt and I'm having a hard time walking up and down stairs, or, blood sugar readings that are really aggressively controlled. How do we find that middle path?
So I definitely think that patients and their family members should be very willing to ask questions about the medications that are prescribed, to ask questions about those potential side effects that are bothersome to them, and to really begin to expect to be engaging in those types of conversations with clinicians. I think many clinicians, I certainly can't say all, I think really do recognize that there are potential harms as well as the potential benefits of medications. The other thing I think that patients can do is really be communicating what outcomes matter most to them. So, kind of like what's the context of their life that sort of should inform their healthcare. If what they really want to be able to do is to walk and get around and have enough energy to do that, and they're less worried about getting their chances of a stroke 5 or 10 years from now to the absolute lowest possible number. I think that that's something they need to communicate. A concept we sometimes talk about is the concept of trade-offs, right? There sometimes are trade-offs. And I think the only way we can figure the right way through a potential trade-off is to know what it is that's mattering most to our patients.
Dr. Boyd, we've heard of a concept called deprescribing. Can you tell us what that means, especially in light of another phrase that we've heard called don't mess with success? So there are a lot of patients who end up on medications, and when they see their doctor 2 or 3 or 4 years later, and everything seems to be okay, it's like, no, we don't want to stop that 8th medicine. Don't mess with success. How can we encourage a review that might lead to deprescribing?
That's a wonderful question. And I think deprescribing is a really important term, which I think takes into account a lot of the things we've been talking about, which is really the idea that we take a thoughtful look about all of the medicines that someone is taking or that we might be considering even adding, and really figure out which ones of those are most needed at this point in time. So there's a lot of that don't mess with success. There's a lot of medicines actually that we can safely deprescribe, while under a clinician's care without people having the recurrence of the symptoms or problems that might have led to it being prescribed. A great example of this is proton pump inhibitors, which are often used for heartburn or reflux. That many times those medicines get left on patients' lists or even added in the hospital, when in reality, after a period of time, with changes in the way we eat and even the way we sleep, that those medicines may not actually be needed anymore. But there's been some studies that have shown that they tend to be left on people's medication lists for long periods of time, even though for many patients, we have great evidence that they can actually be deprescribed safely and that patients will do very well. We did some work that was published in JAMA Internal Medicine actually in December of 2018 about deprescribing, where we asked older adults in a national representative survey about how they felt about medications. And over 90% of older adults said that they'd be willing to stop taking one or more of their medicines if their physician said it was possible. And 2/3 of them actually wanted to reduce the number of medications. And so I think this is great evidence that clinicians should be having more thoughtful and detailed conversations with patients about whether or not there are things on the list that can be safely deprescribed. And a key thing is that, it's not like a permanent decision in many cases, right? If a person ends up needing the medication again down the road, it can be represcribed. But that I don't think that our mantra should just be, well, it's been working. So even though you're on an ever increasing number of medicines, let's just keep them all going. Because we have actually good evidence that makes people more likely to be at risk of an adverse drug event, which is basically a harm that's coming from the medications.
Dr. Cynthia Boyd, thank you ever so much for talking with us on the People's Pharmacy today.
Thank you. Very happy to be here and really glad that your program is interested in this topic.
You've been listening to Dr. Cynthia Boyd, Professor of Medicine at the Johns Hopkins University School of Medicine. She holds a joint appointment in Health Policy and Management and Epidemiology at the Johns Hopkins Bloomberg School of Public Health. Dr. Boyd is a core faculty member at the Johns Hopkins Center on Aging and Health, the Center for Transformative Geriatric Research, and the Roger C. Lippitt Center for Integrated Healthcare.
Lynn Siegel produced today's show. Al Wadarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy is brought to you in part by CocoVia, the maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocavia.com. peoplespharmacy.com.
If you'd like to buy a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1185, or you can find it online at peoplespharmacy.com.
When you visit our site, you can share your thoughts about today's show. Do you think you're taking too many medicines? Please tell us about it. You may also want to consider some of the recommendations by Shannon Brownlee of the Lown Institute. Her idea about prescription checkups with your primary care physician and awareness of the problem, things like benzos, not just among patients, but also among prescribers. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.